This presentation is on understanding health information systems and technology. Our objectives for this presentation are to identify major reasons for the increase in health information system activity in U.S. healthcare, describe current challenges, and explain how HIS initiatives might help, explain U.S. government's role in and goals for healthcare, describe evolving consumer expectations regarding automation of healthcare processes and ways that HIS uses enable patients to become more engaged in their healthcare. Identify ways HIS is used in other countries. Describe the purpose, definition, and scope of HIS using a conceptual model. Define the components of HIS. Explain the progression and maturation of HIS. Describe organizational and community settings in which HIS and informatics can be used. When we look at the current environment, we note that HIS is a priority. And so we have to ask ourselves why that is. Why is HIS implementation important? Why is this high priority on different healthcare professionals and stakeholders lists for healthcare? Well, when we look at that a lot closer, we find that people view the HIS, or health information systems, as a solution or a way of improving the quality and efficiency of healthcare. We also look at those paper records that we have currently been using for the most part up until this time, and how they have become more and more inadequate, not able to handle the current healthcare environment. And what do we see in our current healthcare environment? Well, there has been increases in the volume of information and papers and all types of things that we're dealing with in those processes. So there's an increase in that volume. Also, healthcare has become a lot more complex. So we've seen an increase in volume and complexity. We can use computerization to relieve people of many of those mundane tasks or those day-to-day tasks and to make their jobs a lot more easier. So we're looking to improve cost and quality in healthcare. So when we look at this, this is going to be important for students to learn, because this is the type of environment that we see today. Now, we talked about efficiency, and we talked about quality. And when we're looking a little more closely at efficiency, healthcare costs, if we're looking at healthcare efficiency, healthcare costs is an important discussion or conversation. So what do we see? Well, in 2012, we found that healthcare accounted for 17.2% of our GDP, our gross domestic product. That translates into $2.8 trillion, or $8,915 per person. All right? And the annual average projected growth rate was 6.2% for the years 2015 through 2022. So when we look at that 6.2 projected growth rate, we're talking about potentially 19.9% of our GDP by 2022. These are not good numbers. So there is evidence that healthcare costs are increasing, steadily increasing. When we look at healthcare quality, what are we seeing in our current healthcare? Well, we can take a look at two reports that were published by the Institute of Medicine. In 1999, they published "To Err is Human." In the year 2001, they published the report "Crossing the Quality Chasm." And when we look at these reports, they provided evidence that quality is lacking in our U.S. healthcare today. Also, they provided suggestions for improvement. So they tried to give us some solutions or ways that we can go about improving these quality problems that we see. Let's look a bit closer at the report "To Err is Human." Now, in that report, it said that we had evidence of quality issues. One thing in relation to those quality issues, they talked about medical errors that occur in the hospital. It said that in U.S. hospitals, there are as many as 98,000 patients dying every year due to avoidable medical errors. This is not very good. So, as many as 98,000 patients dying due to avoidable medical errors. So this is not patients who are dying, going in the hospital, dying from the illnesses that they come in with. They are dying due to errors on the hospital's part. This is not good. Now, those numbers translate into 1,310 to 2,917 deaths per 1 million hospitalizations. This number is greater than the number of deaths per year due to motor vehicle accidents, breast cancer, and AIDS combined. All right? And so this report called "To Err is Human" came out in 1999. However, they did an updated study which showed evidence that this number has increased to be more than 400,000 per year. All right? So as a result, we see that our healthcare system is currently ineffective and inefficient, and it has not improved. Now let's look at the other report that the Institute of Medicine published. It's called "Crossing the Quality Chasm." And in this report, they gave us some suggestions for improvement. There are two things we're going to look at here in this report. One is 6 key aims that they outline that we need to do in order, or that we need to have in health care in order to improve the quality of it. One thing it says that our healthcare needs to be safe. So that means we don't want to harm patients, right? So that healthcare cannot harm patients. And so in that report with those medical errors, we are not grasping the safety for healthcare. Healthcare also needs to be effective. So whatever processes we use, protocols need to be based on scientific evidence, right? We want to benefit the patient. We don't want to harm the patient. Healthcare also needs to be patient-centered. So we need to be concerned with patient preferences. We need to be responsive to our patients' needs. Healthcare also needs to be timely. Timely meaning we don't want any delays with the care that we are giving to our patients. Healthcare needs to be efficient, so we don't need to be wasteful, right? We want to use all of our resources to the fullest, all right? Healthcare also, it says, needs to be equitable. That means we want to consistently provide quality care across the board. Now, those are the 6 key aims that they outline in this report, Crossing the Quality Chasm. They also identified 4 key reasons for significant gaps between what we actually see and what we need to be seen, right? So reality versus ideal. So one thing it noted was that science and technology is growing very much, growing a lot more complex. So science and technology is growing very complex. And so when we come up with these innovative ideas, but we cannot implement them, there's a delay between those two things, the innovation and the implementation of these technologies, then we have a gap there, right? And we see that occurring in healthcare today. Our modern medicine is very multifaceted. We have a lot of specialization in healthcare. And then we have lots and lots of technologies that are coming out at an exponential rate. So all these things contribute to a gap between reality and idea. Another thing they noted that causes a significant gap is the increase in chronic illnesses, right? Because we have an aging society, they are realizing more and more chronic illnesses. You know, chronic illnesses is like diabetes, heart disease, those types of things. So we're seeing an increase in chronic illnesses. However, our system is centered on acute illnesses, right? We have acute care hospitals, right? That's what they are dealing with. And so with all these chronic illnesses on the rise, but we have an acute care system, our system is ill-equipped to deal with all these prevalent chronic conditions. This contributes to the gap. All right. Another situation is the inadequate use of information technology. So our technology can be useful to us, but we are not using it to its fullest so that we can realize some of these things that we are saying that they can be a solution to. We feel like these information systems and these technologies can be a solution to our inefficiencies and to our quality issues, but even if we get this technology and we don't use it properly, then we may not see those benefits. One such thing, because we see capabilities such as drug alerts, computerized physician order entry. We'll talk about this more in detail in this course, CPOE, you'll see it called. These are capabilities of a lot of these technologies, but we have to use those in order to see those benefits. And the last reason to make up the 4 for the significant gap is that we have a payment system that provides conflicting incentives, and it does not reward quality improvement. So basically what this is saying is that doctors and the healthcare facilities, all they need to do is to provide that care. It does not matter whether it's quality care, and they get paid for it. So what we need is to have some type of direct correlation between the services that providers and the healthcare facilities provide and what they're getting paid to be related to quality. Is it quality? Was it what was needed? Did it do what we needed to do? They need to have financial incentives to improve, to show quality improvement. This is what that is putting forth. And without that, it causes or contributes to that gap between the reality and the ideal quality that we want to see. Okay, so the Institute of Medicine published these reports, and people responded or reacted, just as you should react when we mention those type of numbers. Because those numbers could include someone you love, your loved ones. So everyone has a stake in this, and everyone wants to see that improvement, and this also includes the government. So, due to these reports, there are several elements and initiatives and laws that they have put forth to assist in quality health care. HIPAA is one of them, and we talk about HIPAA on many occasions in this program. When we're talking about health information management, you can't hardly get past a discussion without mentioning HIPAA. Health Insurance Portability and Accountability Act of 1996. All right, and the thing we can note here is that initially in this, when it came out in 1996, what it was concerned with was the portability of insurance in state jobs. All right, but really what ended up happening is that Title II, Administrative Simplification, that became the big thing. And when people always talk about confidentiality and privacy, you're actually referring to the Title II Administrative Simplification portion of HIPAA. That's actually what you are referring to. In the Title II, this is where your privacy rule falls, your transaction code sets, and those are none other those electronic data interchange standards for submitting claims. That's what that portion is for the Title II section. You have your security rule. You have your unique identifiers rule, and this is when we're talking about the unique identifiers rule, we're looking at that national provider identifier, those numbers that they're assigned to providers. They're unique numbers, so when they submit those claims, they use those numbers, and you know which provider that claim is for. Then you also have your enforcement rule, which is an important aspect of your Title II, because this is where it defines those civil financial penalties when you violate HIPAA rules and laws. All right, so it is that portion that's going to enforce all these things that are laid out in these other sections. So that's very important, because if you don't have any type of enforcement, then people may or may not follow those rules. So all in all, when we're looking at this Title II, excuse me, Administrative Simplification Act, its goal is really there to improve the efficiency of the standards that the government is using in the communication of that health information. All right? So it wants to protect that patient health information. And you'll see the term "you covered entities" in this Title II Administrative Simplification Act. And covered entities are those entities that have to be compliant with these rules set forth in HIPAA. All right. However, and it really started out initially with we're talking about Medicare. But every time when you talk about Medicare, what you have to realize is Medicare sets the standards and the benchmark for all other payers in the healthcare system. And so what Medicare does, then the others are going to follow. So this Title II really has a big impact, all right, on how things are done. We also saw other initiatives to come along that dealt with health information systems and technologies, EHRs, and all those types of things. The government was interested in implementing HISs. They want to improve those qualities. So we had two presidents that we're going to mention here in terms of the government's role and influence with HISs, with health information systems. And the first one we're going to look at is President George W. Bush. All right? He put forth several initiatives. He signed several initiatives to provide seed grants for pilot projects that test different ITs or different technologies in the healthcare setting. So what we're doing, we're looking at improving quality. For example, the Medicare Prescription Drug Improvement and Modernization Act of 2003. And what that act did was it developed standards for e-prescribing, right? So when you e-prescribing is when your medications in an electronic format. So that came from that Medicare Prescription Drug Improvement and Modernization Act of 2003. This was an initial step in implementing electronic health records. All right. This precipitated the establishment of a Commission on Systematic Interoperability. All right. So it was looking at interoperability standards for that e-prescribing system. Now, President George Bush also established what we call the Office of the National Coordinator, or ONC, Office of National Coordinator of Health Information Technology. That's under your Health and Human Services Department. He also established or did an executive order. That's your 13335. I was trying to think of a word to use there. That was in 2004. This executive order, incentives for the use of health information technology and establishing the position of the National Health Information Technology Coordinator. We also had the President's Health Information Technology Plan. And what that plan was, that it was going to take 10 years to get all Americans online with electronic health records. We didn't quite get that together there, but it did set the ball rolling for all these other things that are coming about or that we see now. These were built on other initiatives like the Consolidated Health Informatics Initiative in 2003, right, where they had uniform standards for electronic exchange across federal healthcare entities. We had other encouragement incentives from President Barack Obama with ARA and the HITECH Act. HITECH Act is actually a component of ARA. It provides stimulus, financial incentives that are stimulus money. You might, if you follow politics, you will hear that term being thrown around. And so basically, with this HITECH Act, what it set out is it created what was a strategic plan for a nationwide interoperable health information system. So they created a strategic plan for a nationwide interoperable health information system. And they had to update that strategic plan annually. Right? It also put together two committees to lead and advise the coordinator, the Office of the National Coordinator, and that was your Health Information Policy Committee and your Health Information Standards Committee. All right, so when we're looking at that stimulus, there was $787 billion in that stimulus package. And they had $30 billion in HIT infrastructure and Medicare and Medicaid incentives. So those incentives were going to come through Medicare and Medicaid. And you might think, oh, okay, that's a lot of money to put out there to implement a health information system. But when they looked at that, when that Congressional Budget Office calculated how this was going to work out, what they found was that when they invested this type of money into this implementation and all these things that we're talking about, it was going to save the government $10 billion and also generate additional savings. So they did have an impetus for giving out that money or providing that incentive, that financial stimulus incentive. All right. Now, also in line with that, when that was done, there were major grants that were established for universities and colleges to create training programs so that they can put out individuals who were trained to use these systems and know how to implement them and those types of things. This is synonymous to, I actually used some of that. I got a scholarship to finish a 6-month program for health information technology professionals where they looked at just that. All right, and so I actually took advantage of some of those grants. Now, when we're looking at HITECH Act, the HITECH Act establishes what we call meaningful use criteria. Meaningful use is actually looking at or indicating those features and functions and capabilities that an EHR has. And once you use it, it improves care. So when these people these eligible providers are trying to get these money incentives, they have to show meaningful use, meaning they have to use these features, functions, and capabilities, or show that they are meaningfully using these EHRs by using these features, functions, and capabilities. If a provider meets the criteria that's required, then that provider will receive those incentive payments. Now, after 2016, the year 2016, if they have not met this criteria, then they're going to start receiving penalties. All right? So in 2016, they're going to receive a loss of 1% of their Medicare payment. In 2017, it goes up, you're losing 2%. In 2018, if they still haven't met the criteria for meaningful use, then they're going to lose 3%. So that's very significant. You know, there are a lot of Medicare patients and a lot of providers treat lots of Medicare patients. So this will be a considerable concern for them. So if we look specifically at Medicare, at the meaningful use, here's a table. The meaningful use is going to occur in 3 stages. And stage 1 has already passed. Stage 1 was 2011 through 2013. And in stage 1, the meaningful use was focused on data capture and sharing of data. And if you look closely at that column, you'll see the criteria that they were looking at. They wanted the provider to electronically capture health information in a standardized format. They want the provider to use that information to track key clinical conditions. Then communicate that information for care coordination processes. So you want to coordinate that care with other providers, that information that you have captured and standardized, and you've tracked it. And so now we need to communicate it to assist in those coordination processes. Then you want to report the clinical quality measures and public health information. So you got to report that information. And then use the information to engage patients and their families in their care. That was in stage 1, the criteria that they was focused on. Now in stage 2, that was 2014 to 2015. That's where we are now. And here they focus on advanced clinical processes. So we're going to build on what we're already doing in stage 1. So in stage 2, they want more rigorous HIE. HIE is Health Information Exchange. So more rigorous health information exchange needs to occur in stage 2. Increase requirements for e-prescribing and incorporating lab results. All right? Electronic transmission of patient care summaries across multiple settings. More patient-controlled data. So we're going to increasingly use these capabilities. And then there's stage 3. We're not there yet. That's 2016 through 2017. And if you recall, I just mentioned penalties that will be levied if people, eligible providers, are not meeting these criteria by the time we get to stage 3. So in stage 3, we're going to focus on improved outcomes. So we want to start seeing improved outcomes here by using all these capabilities in stage 1 and stage 2. So here it says improving quality, safety, and efficiency, leading to improved health outcomes. Decision support for national high-priority conditions. Patient access to self-management tools. Access to comprehensive patient data through patient-centered health information exchange, or HIE, and improving population health. All right? So those are your 3 stages for your meaningful use. Now, we mentioned patient-centered, responsive to the patient. So we have to consider the expectations of your consumers and how we deal with consumers in the healthcare process. Now, if you look at the trend now with patients, I don't know how old people are who are listening to the presentation, but in the past, and we can say kind of further past, or maybe not too far past, patients were more or less passive, and so the doctor is whatever the doctor says, whatever goes. They didn't take it any further. But if you look now at the patients, and when I talk about patients, people who are using the healthcare resources, going to the doctors or what have you, patients are more engaged. And what they found through research is that when patients are more engaged, outcomes improve. All right? And when they realized this, then we saw many adaptations to healthcare process in the way that clinicians did things in order to engage and involve patients more in their healthcare process. All right? And with the technology that we have now, it has created possibilities where loved ones can connect with their family in a hospital. So the family members in the hospital, the loved ones somewhere else, and they can connect with them there. Care settings connected across continuums of care, and new devices to facilitate that connection. And so with all of this technology is allowing for that health information exchange. It makes it possible. Now, we see that in some places, but right at this point, it is not everywhere. So we have the infrastructure that's necessary, but it's not necessarily all over. So certain pockets of places have these types of capabilities. However, with all this these different technologies that are intersecting, the different ways that we're transmitting our patient health information, and we're concerned with the security and the confidentiality of that. We're seeing different organizational models coming about. It really places new demands on our HISs. All right, we have to think about workflows and how these, when we implement these things, how it impacts those workflows, how we're going to handle our information, and all those types of things. But also always being cognizant of quality, privacy, confidentiality, and all those things. Now, we're not the only country who is interested in technology, EHRs, health information exchange, health information systems. And so when we look, and we looked at a couple of countries here, and we found that more than 90% of these countries' general practitioners, and we're talking about Australia, New Zealand, the Netherlands, and the United Kingdom, more than 90% of the general practitioners report using their EHRs. All right, and this is more like in an ambulatory setting. But when they looked at the hospitals, only 10% of the hospitals in those countries were meaningfully using EHRs. Now, in the U.S. and Canada, when we looked at the ambulatory, it was only 10 to 30%. So we are actually not using the EHRs as much as these other countries that I just mentioned. But regardless of whatever type healthcare system that's being used, they all have to deal with similar obstacles. If we want to see implement this HIS infrastructure that we need in order to support the type of health information systems on a national scale, then we have to align both our political, our popular, and professional energy in order to muster those resources and commitments to make that happen. And it doesn't matter if we have a closed health system or we have an open health system or what we have. All those things have to align for us to realize the type of health information system and health information exchange we want to see on a national basis. Now, we've been talking about the health information system, but we really need to know a little bit more about exactly what that health information system is, what's the scope of its function, the components that make up this system, and we're going to actually discuss this in terms of what we call a conceptual model. And as I go forward talking about the conceptual model, we will understand exactly what that is. There is a figure here on that slide which illustrates that HIS scope model or that conceptual model that we're speaking of. It helps us to understand the relationship among the major elements of a health information system. So if you look in here, it says you have the HIS, the systems and management, health informatics, data and analytics, research, policy, and public health. All right? When we look at when we look at this conceptual model, what we need to understand and realize is that data is created and captured by a properly implemented HIS. And so that data and information is very important. But we have to have a properly implemented HIS in order to properly capture and create data. right? And if you notice in this conceptual model that the health information system is right at the bottom or in the core of that figure, because the HIS serves as the foundation for all these other components, right? And so the source system and devices, that source system, that core or that foundational system is the essential building block for all other advanced uses. So we have to start with a properly implemented HIS that's going to properly capture and create that data, and then our rewards or our benefits will flow from there with all these other uses that we have. Health information system components rely on the HIS for the capabilities and data that the HIS creates and captures so that these spheres can exist. This is the HIS scope model. All right, so we got to start with that HIS system as the foundation. All right, and all these other spheres that we see, our other uses, rely on that data that has been created and captured through a properly implemented HIS. Okay? All right. So that kind of flows into what we were talking about in terms of our systems and our management, right? So we have to have that properly implemented system so that we can manage that data. But we also, in that sphere after systems and management, it mentioned health informatics, right? Health informatics. When we talk about informatics, we're looking at the use of information systems and technology to redesign, improve, and recreate the way work is done in different healthcare disciplines. All right? So we're looking at, or we're focused on when we're talking about informatics, on certain quality or process improvement objectives. All right? We're looking at the use of the capabilities from our computer that the HIS provides to end users. Right? The use of the computer capabilities that HIS provides to end users, this is what informatics is comprised of. Now, data and analytics. The value that we're going to realize from our HIS is locked up in our data. So that's where the value is, that data that we are trying to get at. Because that data, we're going to get rewards from that data by secondary uses of that data. So we'll have a primary use where we're generating that data from day-to-day activities, but then we take that data and we have secondary uses outside those primary uses, and we create information. We aggregate and compile that data, and we create that information, meaningful information, so that we can do other work. And therefore, in that conceptual model, that data that we created and captured, these other things are secondary uses that creates rewards for us on an exponential scale. All right? So our being able to create that information, being able to analyze it, we gain knowledge, we learn. All right? So we get real data from real activities, from real organizations through real processes, real analysis and research, drawing real inferences, associations, outcomes, and evidence. That's the reward. All right? And so we have to be stewards of this data and information, and we have to value it. All right? Because this is where our benefits are going to come from. Now, when we look at the sphere of research, policy, and public health, When we capture and create that data, it is available for research, right? And then we have our policymakers who use that research to help them predict long-term implications, right? When we're looking at the health of the public. So they take their research, they analyze it, and it will guide the policies that they make in terms of public health. When we look at public health, our scope is larger than just a person or a patient or a group of patients. We're looking at possibly the entire country or on an international scale when we're looking at that. And so what we're saying is we can take this data and create information, and we can look at it and analyze it on many different dimensions. We can basically cut it any way that we want, whatever we're looking at, right? From many different perspectives. Many different variations are available for us to study and analyze that data, or generalize, or any way we want to cut it. So it's just endless possibilities. And so it really lends itself to all this information. We just have a lot of information that we can do things with. And technology helps us with that. Now, progression and maturation of the HIS. We can outline the steps for progression and maturation in 4 steps. And number 1 being our foundation. And we know that foundation, when we look at it, conceptual model is our health information system. It's that core, it's that foundation, right? Where none of these other subsequent layers can exist without it. Number 2 is use. And we term or define informatics as being that use of those system capabilities, right? So our systems support those daily activities, and they also help develop new, streamlined, and more effective workflows. And so we're discussing that in informatics. So that's what our intention is to improve upon those healthcare processes, all right? Then 3 is learning and knowledge. And another term you may hear, and we're talking about learning and knowledge, that's business and intelligence and clinical intelligence. All right? Because we use that data and we learn and we gain new knowledge. When we take that transactional data and they create and capture it in that HIS, then they coalesce it in databases and analytics platforms, and we use it for analysis and creation of information. All right? So we get enhanced knowledge from this system. This is our secondary uses. And then once we learn these things and we find out ways to improve the way we do things, then that promotes and creates change. All right? Based on the evidence that we have gathered from analyzing that data, we can bring about change. So there are many organizations and players when we're talking about using healthcare data, right? Because we need to take this system. How are we going to use this HIS, right? And so it's going to depend on who our users are and how they're going to use that data. So one user here we're looking at is your inpatient, your outpatient, and your ambulatory healthcare provider organizations, right? So they use data. And actually the first systems that came on the scene, basically all they did was support your financial accounting and billing functions, all right? And then around the 1970s, we start seeing software vendors for health information systems. They came on the scene. And they would either get software from hospitals who are using some kind of in-house software, and then they'll send it and commercialize it, or they would develop, the vendor would develop the software and commercialize and license those to hospitals. So you had two different types of vendor software that had emerged there in the 1970s. In the 1980s, clinical systems began to support automation of specific departmental areas. So we start seeing clinical systems and not just really financial accounting and billing systems. In the 1990s, they continued to grow and support many different functions than they used to, and this is when EHRs emerged. And so your inpatient and outpatients and all your ambulatory, they were using these systems for their financial accounting, their billing, and other clinical situations that were going in various departments. They were using your HIS. In your patients and consumers, they also use HIS. We talked about them being more involved and engaged these days. We see a lot of mobile computing going on in our society that also encourages the patient and consumer use and the internet. That was the other thing that really got us to the point where we craved and we wanted information. On that internet, we are able to access a lot more information than before, and we are very much more much more engaged patient. And we talked about an engaged patient improves outcomes, and so that this is an important aspect. Patients are more empowered today. They are able to access more information, and they expect to get more information. All right. Another users will be your payers, your insurance companies, which is pretty much the same thing, and your government programs and agencies. You got many different types of payers. You got your private insurance, you got your government insurance, you got your military insurance, all these types of payers and insurance that all use health information systems. Military organizations like your Veterans Administration, your public health organizations like your CDC, Centers for Disease Control. Everybody, I'm pretty sure, is probably familiar with them. All right. With public health, we know this information that's in the health information system is important to them because they monitor the public. They do surveillance of different diseases and stuff to make sure that we stay healthy, and they look out for incidences of diseases and things like that. So they threat to our population's health. Now you also have your health information exchanges and your regional health information organizations that are HIS users. They are pretty much interested in data sharing, sharing them across the board in competitors, in all types of healthcare organizations and entities. They are promoting collaborative arrangements. They want to provide this information across the continuum of care, so this helps the patient to get continuous care, quality care, and all of the providers that are involved in the care, no matter whether they work at a hospital or a dentist or a primary care provider or specialist or whatever, can access that information in a secure location for the benefit of that patient. And so many, you have your regional organizations that participate in these consortia, hospitals, hospital systems, clinicians, and whatever, and share those data in across those systems. all right, and for the support of the patient. That's what it is for. They're able to access the information in a more timely fashion. If you remember, we talked about minimizing delays. They decrease duplication, and they speed up diagnosis and treatment, and all types of benefits come from being able to share the information in a common pool. However, in theory, those RHIOs, regional health information organizations, will be very beneficial, but at this point there has been mixed success in terms of these consortia that they have, these collaborative situations or collaborative arrangements. However, they continue to progress with them. There's a lot of different reasons why there has not been success across the board. It might be a poor business model, or you have like a cooperation between your providers who are in that area, because a lot of them could be competitors or something of that nature. So it's just a lot of things. It's a lot of multifaceted areas that have to work for you to see full success. However, they're beginning to show signs of sustainability from what the studies are showing. They're enhancing their products. The systems are becoming more robust, and they're being able to get the capabilities needed to share that information securely and facilitate that information across those regional providers. There are regional health. We do have a regional health information organization. This area is called Big Bend, Rio. There are also some in other areas in Florida. Simply by clicking on the internet, you can take a look at those. And so these things are here to promote the sharing of that information to increase quality and efficiency in healthcare. Also, you have seen more popularity with your RHIOs. If you recall, in a couple of slides earlier, we talked about meaningful use, and one of those criteria is for health information exchange. And due to that meaningful use criteria, those regional health information organizations can really help with providers and entities satisfying that criteria. Now, you also have external regulatory reporting, research, and public health organizations that uses HIS. And you have many different types. With a lot of these organizations, they are accountable to the community, board constituents, regulatory oversight bodies, other third-party organizations, and some of these third-party organizations, they are there to set standards, to measure the quality and cost of services that our providers provide. They collect reported measures from participating health providers. They have benchmarks out there for them to strive to and evaluate their performance against those benchmarks. One example is the Leapfrog Group. And they look at promoting improvements in safety of healthcare. So they do that by giving data to consumers so that they can make more informed choices about the hospitals that they want to deal with. You also have a third-party external reporting agencies that monitor key metrics regarding quality of care for different states, various states and countries. One example of that would be your OSHPD, and basically that's the Office of Statewide Health Planning and Development of the California Health and Human Services Agency. So this is for the state of California. So they look at those metrics for quality care. And basically it looks at safety in hospitals and other healthcare settings. and that's what its interest is. Then other external organizations will be like your joint commission, and it inspects and accredits hospitals and seeing and ensuring that they're meeting the set of standards, those rigorous set of standards that they lay out there for them. And you also have other organizations that do reporting that they have to report to, like a cardiac reporting organization. They establish cardiac mortality rates on a national scale, and so organizations have to report different data and report to that organization, and it is mandatory, right? But you also have voluntary reporting relationships as well. Examples of that would be like your Institute of Healthcare Improvement. You also have what we call CHART, California Hospital Assessment and Reporting Task Force. It's a voluntary program in California. All right. So what it do is gives report card type evaluations and peer comparative data that hospitals can use to assess themselves and benchmark and improve their quality and cost performance. All right. So in order for all of these agencies and public health organizations and any of these users, for any of this to occur, they have to be able to take that data and create it and capture it and compile it and manipulate this data into information for us to benefit. And so that HIS is very important in our efforts to do this. And all of this represents what we call secondary uses of data, and that's where a lot of our value lies in those secondary uses. Well, that's going to conclude my presentation on understanding